It's showtime, folks. Multiple sclerosis, Guillain-Barré, or as some of you say, Guillain-Barré, myasthenia gravis. Oh, it's a face, man. Ooh, it's the trigeminal nerve. What motor function does the trigeminal nerve have? It has sensory motor function. No, it's a sensory function. Woman comes in with lancing, meaning being stabbed in the face, and her left cheek begins suddenly and is really debilitating. In other words, trigeminal neuralgia, or tic douloureux, is so incapacitating people have dropped to the ground. However, something strange here. She's also got lower extremity hyperreflexia and muscle tone. Wow. So this tells you that trigeminal neuralgia can be the first finding of a person who's got myasthenia gravis. Bilateral upper extremity, lower extremity hyperreflexia, muscle tone, spasticity, right-sided optical nerve pallor. That means optic neuritis. She had another episode last year. So it's multiple parts of her neurological system over time causing this problem. What's the diagnosis? It's multiple sclerosis. Multiple central nervous system problems over time. The treatment for the facial pain used to be carbamazepine. Now it's carbamazepine. And if the carbamazepine does not work, you switch to other anti-epileptic drugs like valproic acid or phenytoin, because many anti-epileptic drugs are also pain medications. Carbamazepine just happens to be first for trigeminal neuralgia, but it could have been valproic acid, it could have been phenytoin, it could have been lamotrigine or pregabalin or gabapentin, because those are seizure medications that also treat neurological pain. Well, you're gonna love neurology with me because neurology is very blocky and concrete. The same way for stroke, head CT is the best initial test always. Then multiple sclerosis, the best initial test is MRI. The most accurate test is MRI. And you only do cerebral spinal fluid testing if the MRI is equivocal. The first test is MRI, the best test and most accurate test is MRI, and the only time to do CSF for oligoclonal bands is when you have an MRI that's equivocal. The acute treatment for acute multiple sclerosis exacerbations used to be steroids, now it's glucocorticoids. It hasn't changed. Intravenous immunoglobulins do nothing. Glatiramer is one of the many drugs to use to prevent progression. Glatiramer and medications like natalizumab, nitoxantrone, fingolimod, vedolizumab, mitoxantrone, copolymer 1, beta interferon, all prevent progression, but they don't do anything for the acute episode. The only treatment for acute episodes was steroids, is steroids, gonna be steroids. Which of these arrest the progression of disease? Mitoxantrone, glitiramer, beta interferon, fingolimod, glitiramer, interferon, but not just glitiramer and interferon, so many more. Natalizumab, glitiramer, beta interferon. What else is beta interferon good for? What else is beta interferon good for besides multiple sclerosis? Nothing. Nothing. So, my goodness, so difficult. The complications here. Spasticity and slow spasticity. It's supposed to be the spasticity find. And decreased gait problems, walking problems. Okay, spasticity gets treated with baclofen. Spasticity gets treated with tizanidine. Spasticity gets treated baclofen, tizanidine, intrathecal baclofen. You can inject the baclofen directly into the cerebral spinal fluid. The dalfampridine is the gait problem can be managed specifically with dalfampridine, increases gait speed. Dalfampridine for walking speed. What do you do about the fatigue, the severe fatigue of multiple sclerosis? That gets treated with amantadine. The other thing, amantadine for fatigue, baclofen and tizanidine, and sometimes Botox injections for spasticity. Gait for dalfampridine, fatigue, amantadine. The urinary problems, urge incontinence. fatigue, amantadine, spasticity, baclofen, tizanidine. The urge incontinence, you can use oxybutynin, tolterodine, sulfenacin, darafenicin. All of those are anticholinergic just for the bladder. Sulfenacin, darafenicin, trospium, oxybutynin, tolterodine. Big words, they hurt my brain, stop it. All the urge incontinence. Woman comes in with blurry vision, especially when looking to the right. One eye stays in the midline, the other one has nystagmus. Donkey. One eye can't cross the midline, the other one has nystagmus. That is medial longitudinal fasciculus defect, also known as an intranuclear ophthalmoplegia. One eye can't cross the midline, the other one goes donkey with nystagmus. You like that? Donkey with nystagmus. Medial longitudinal fasciculus, intranuclear ophthalmoplegia. Woman comes with problems with the lower extremities and visual disturbance. The MRI is equivocal. What do you do when there's an equivocal MRI? An equivocal MRI. MRI is the best initial test. MRI is the most accurate test. When the MRI is equivalent, you look for oligoclonal bands. Oligoclonal bands is looking for specific antibodies. You're doing a cerebral spinal fluid. Look at that. Isn't that interesting? CSF tap, lumbar puncture. You're looking for specific bands of immunoglobulins in the cerebrospinal fluid. And the only time to look at cerebrospinal fluid is in the small number of people that have an equivocal MRI. When are visual and auditory evoked potentials the answer? When you shine a light in the eye and put some sound in the ear and you see how long it takes for the sensory transmission to go around, those are never correct. Never correct. They were replaced by the MRI. Which of these multiple sclerosis medication is cardiotoxic? Which multiple sclerosis medication is associated with acute myelogenous leukemia? The answer to this is the same, mitoxantrone. Mitoxantrone. See, steroids for acute exacerbations is very clear. But which is the best drug to prevent progression? Glatiramer, beta interferon, mitoxantrone, natalizumab, dalfampridine. No, dalfampridine is just to increase walking speed. Dalfampridine is not disease modifying. Fingolimod, which of them is the best? Not clear. Which is the best? Not clear. What about adverse effects? That's clear. Well, if you can't choose between glatiramer, beta interferon, mitoxantrone, natalizumab, fingolimod, dimethylfumarate, if they're all disease modifying, how do we ask you a question? If dimethylfumarate, fingolimod, natalizumab, mitoxantrone, if they all decrease progression, then how do we construct a question if the efficacy is the same? Because first, when you're answering on your test, first comes efficacy, then comes adverse effects. Which of them is cardiotoxic? Mitoxantrone. Which of them is AML, acute myelogenous leukemia? Mitoxantrone. Which increases walking speed? Specific indication, dalfampridine. Which of them is not disease modifying? Dalfampridine. Oh, look at the choices. Yes, daclizumab, another one, as if you didn't have enough things to memorize. Are they all disease modifying? Ocrelizumab, it's a CD20 drug, like rituximab. The CD20 drug. Dalfampridine increases walking speed. Ocrelizumab is a CD20 drug. All of these drugs are used for multiple sclerosis. But how are you going to get a question? Alemtuzumab. Now, I don't like to inflict all these mabs on you, they're a pain in the ass. But the alemtuzumab we do because it's got two indications. What's the other disease that gets treated with alemtuzumab? It's got two diseases it works for. It's an anti-CD52. Holy crap, man. Alemtuzumab is also used as a drug in chronic lymphocytic leukemia, CLL, and as an alternative in aplastic anemia. So I wouldn't torture you with this, except it works for multiple diseases, aplastic anemia and CLL. A patient with multiple sclerosis and severe spasticity that's not responding to baclofen or tizanidine. Ooh, tizanidine is an alpha drug, not useful for anything except spasticity. Tizanidine. Beta blockers don't do anything for muscles. Calcium blockers don't do anything either. Phenytoin and carbamazepine are pain medications, but what you need is to unlock and relax muscles, and botulinum toxin unlocks and relaxes muscles. Botulinum toxin. A woman develops a thick tongue on the hot tower. Well, multiple sclerosis. You know that people before there were MRIs used to take people with unclear neurological problems and dunk them in a bucket of hot water and see if it got worse? Yes, so multiple sclerosis gets worse in hot water. It gets worse in hot water. Ooh, there it is. Multiple sclerosis gets worse in hot water. Ooh, sorry, that's like PML, progressive multifocal leukoencephalopathy. What's associated with worse? Which of these drugs gets a PML? Natalizumab. Natalizumab is an alpha integrin inhibitor. Alpha integrin inhibitor. Ooh, alpha integrin inhibitor gives you PML. Which of these will modify disease when fatigue is severe? Okay, which of these will modify progression of fatigue? Modafinil, steroids, intravenous immunoglobulins, ocrelizumab, amantadine. Well, amantadine works for fatigue, but it doesn't modify the disease. Fooled you, sorry. Amantadine is good for fatigue, but won't modify the disease. Ocrelizumab is an anti-CD20 inhibitor. That is also one of the medications like rituximab. Some of these anti-CD20 drugs are good for CLL and for lymphoma. What's modafinil? Modafinil? Modafinil is basically speed. It's a stimulant. It's like a triple espresso. It's to keep people awake when they're super tired. Which of these helps multiple sclerosis? Ooh, vitamins help multiple sclerosis? Vitamins? Must be fish oil. No, it's vitamin D. Vitamin D helps multiple sclerosis? Yeah, it is. It is. Who'd have thought, right? It's a memorizable fact. There's no way to figure it out. It's just the way it is. Oh, this is too long. A woman comes to the emergency department with difficulty walking. We've changed diseases. Right? Symptoms began 2 weeks ago. Now what's happened is that it goes from her legs and it's ascending up. It's ascending up. Now she's got difficulty breathing. Recently had diarrhea. Lower extremity weakness with decreased reflexes. Decreased reflexes. Decreased reflexes. Lower extremity weakness that's moving up with decreased reflexes. What gives you bilateral lower extremity weakness and decreased reflexes? Bilateral lower extremity weakness can be a lot of things, but decreased reflexes, you see, cord compression and other spine diseases tend to give you hyperreflexia. But this is ascending weakness and a loss of reflexes. This is Guillain-Barré. Ascending weakness and a loss of reflexes. 10% comes from the uppers. It's Miller-Fisher. Miller-Fisher, 10% come from upper extremities. Ascending weakness and a loss of reflexes is Guillain-Barré. Welcome to Guillain-Barré. Guillain-Barré hasn't changed one word in 30 years. Ready? The most accurate test for Guillain-Barré has always been nerve conduction studies. Because just as multiple sclerosis is all central nervous system, Guillain-Barré is all peripheral nervous system. So nerve conduction studies is the most accurate test. But what should you do first? What should you do first? Plasmapheresis treats Guillain-Barré. Nerve conduction electromyography is the most accurate test, nerve conduction. CSF protein levels are high. CSF cell count is low because it's normal, it's not inflammatory. Protein is high and cells are low. Protein is high, cells are low. The so-called albuminocytological dissociation. But the most important thing with Guillain-Barré is that as it ascends from your toes up to your nose, to be sure that your diaphragm is not being involved. Because your diaphragm is involved, you're gonna die. So the most important thing to do first is to be sure that the respiratory muscles are not involved. Be sure that the respiratory muscles are not involved first, because that will kill you. Yes, with respiratory muscles, diaphragm. And 30 or 40% of people with Guillain-Barré have significant respiratory muscle. You can involvement. You can either say forced vital capacity or peak inspiratory flow. Forced vital capacity, or the decrease in the ability to inhale. The initial therapy was intravenous immunoglobulins or plasmapheresis. The initial therapy is still intravenous immunoglobulins or plasmapheresis. I personally can't see why anybody would do plasmapheresis if they can just infuse some intravenous immunoglobulins. But the intravenous immunoglobulins or plasmapheresis are the two therapies. The key issue is here in Guillain-Barré, IVIG or plasmapheresis first, always. Steroids, never. They just don't help. Most accurate test, nerve conduction study. First thing to do is make sure the respiratory muscles are not involved. The most effective therapy, never combine them. No combos, no steroids. No combos, no steroids. No combinations of IVIG and plasmapheresis, no steroids. They don't help. Also, if you give intravenous immunoglobulins and you do plasmapheresis, plasmapheresis is essentially a washing machine for blood. You're taking out all the plasma and throwing it away. So if I put intravenous immunoglobulins in this arm and I do plasmapheresis over there, it's like throwing them in the garbage. The most accurate test, nerve conduction studies. Muscle biopsy is for polymyositis. Acetylcholine esterase antibodies is for myasthenia gravis. Okay? Muscle biopsies for polymyositis, acetylcholine esterase antibodies, anti-acetylcholinesterase receptor antibodies, to be precise. Receptor antibodies are for myasthenia gravis. Nerve conduction studies. What we're doing is we're putting a stimulation in there and seeing how long it takes to be received over there. Basically, shooting electricity in through people's bodies. Now, pulmonary function test, peak inspiratory pressure, forced vital capacity, is critical to do first, but there's nothing specific about it. When are steroids the answer for Guillain-Barré? Never. Next one, 73-year-old woman, weakness and paresthesia in distal hands and feet. Absent patellar reflexes. Next step, pulmonary function test is not there. Should you do the nerve conduction studies? Should you look for the high protein and no cells? Or should you go straight to IVIG? But wait a second, Conrad, you said both IVIG and plasmapheresis do work. Yes, but why would anybody use plasmapheresis when you can just squirt some intravenous immunoglobulin to someone? I wouldn't. The point about this question is, if you think that you've got Guillain-Barré, weakness and paresthesia in the distal extremities, and absent reflexes. If you think that you've got Guillain-Barré, Guillain-Barré, don't wait for confirmatory testing with nerve conduction studies. Weakness in the lower extremities, loss of, I've heard this before. Okay, I'm not asking you what the diagnosis is. I'm asking you, what is the bug? What's the bug? What's the bug? What's the bug? The bug is, scombroid is histamine fish poisoning. 10 minutes after you eat it, nausea, vomiting, wheezing. E. coli 157 gives you hemolytic uremic syndrome. But Campylobacter is an immunologically active bug. Campylobacter is an immunologically active bug. It causes inflammation. That's why Campylobacter can cause you to have ulcers and even stomach cancer. 38-year-old woman with 3 months of lower extremity weakness. I've had this before. Proximal and distal muscles? But months. That's a long time. That's a long time. This looks like Guillain-Barré, but it's chronic. You know, the other name for Guillain-Barré is acute inflammatory demyelinating disease. Acute inflammatory demyelinating disease. The other name for Guillain-Barré is acute inflammatory demyelinating disease. But this is kind of more chronic. So what would you call acute inflammatory demyelinating disease if it was chronic? If it was chronic, you would call it chronic inflammatory demyelinating disease or polyneuropathy. And what's the big difference? Steroids work. Oh, that's the biggest difference. There's a chronic version in which steroids actually help. Okay, 38-year-old man, he comes because he's seeing double. By the way, what's the strongest muscle in the human body? The strongest muscle in the human body? The strongest muscle in the human body. In class, the two wrong answers are gluteus or quadriceps and tongue. People always saying tongue. Like, tongue? Strongest muscle in the human body? You mean if somebody's car got stopped and you're like, don't worry, I'll push it for you. The strongest muscle in the human body is actually, in a man, it's the masseter, not the tongue. In a woman, it's the uterus. But the uterus doesn't work regularly, and the masseter. So what you get when you have decrease with muscles is that what you have is a decrease in the ability to chew. But what we see here is a lot of ocular problems. Why do we see double? Because your eye muscles are getting tired. It worsens over time because your eye muscles are getting tired. Worse later in the day because your muscles are getting tired. Ptosis because your muscles are getting tired. But the pupils stay intact. The pupils stay intact. Increasing muscular fatigue over the course of a day is myasthenia gravis. Myasthenia gravis. Botulism is tightness. Guillain-Barré is weakness, but it starts from the toes. The other thing that used to be, that looked like Guillain-Barré was polio. Polio has been eradicated in all but 2 or 3 countries in the world. But what you see, so polio looks like Guillain-Barré, ascending weakness and a loss of reflexes. Polio, ascending weakness. Parkinson's is a gait disorder. Now, myasthenia gravis presents as muscle weakness. Muscle weakness worse at the end of the day. So your case will either describe, as this one did, double vision, ptosis, or double vision and ptosis and decreased ability to see. The pupils stay intact because the pupils are not nicotinic receptors. The pupils are muscarinic receptors. That's why all the drugs like tricyclics and atropine affect your eyes, but they don't affect your neuromuscular junction. So the best initial diagnostic test for myasthenia gravis, remember, double vision, decreased ability to chew. The best initial diagnostic test is not, the best initial test is not edrophonium testing. It's not. The best initial test is not edrophonium testing because edrophonium is not precise. The best initial test is to look to see if you're making antibodies against acetylcholine receptors. The best initial test is the acetylcholine receptor antibodies. And acetylcholine receptor antibodies will be positive in 80 to 90%. Tensilon or edrophonium testing is neither as sensitive nor as specific as acetylcholine receptor antibodies. Next, muscle biopsy is used in polymyositis, not myasthenia gravis. Next, chest x-ray should be done, but it's not what you do first. Chest x-ray and chest CT are to look for thymoma, but they're neither first nor most accurate. But you should look for thymoma, but not first nor accurate. Electromyography, single fiber electromyography actually is the most accurate test, but not first. If the acetylcholine receptor antibodies are negative, what blood test would you do first? MuSK. JOE is for lung involvement in polymyositis, dermatomyositis. JOE is for lung involvement in polymyositis. See you in the rheumatology section. We'll see if you got involvement of JOE lungs. Aldolase is for polymyositis. What's MuSK? Anti-MuSK. Most people incorrectly say anti-MuSK is anti-muscarinic receptor because it's not the muscarinic receptors that are affected in myasthenia gravis. It's the nicotinic receptors that are affected in myasthenia gravis. Anti-MuSK is muscle-specific kinase. Muscle-specific kinase. So I said that acetylcholine receptor antibodies are present in 80 to 90%. About 50% if you just involve the eyes, if you have myasthenia gravis just involving the eyes, because some people just have ocular myasthenia. Remember that myasthenia spares the pupils because the pupils are muscarinic receptors. Of the 10 or 20% that have negative acetylcholine receptor antibodies, half of them, a little bit more than half, will be anti-MuSK positive. The most accurate test is a single fiber electromyography. The best initial test is acetylcholine receptor antibodies. Anti-MuSK, if those receptor antibodies are negative, you must be looking at the chest because you're looking at the chest to see if you have thymoma or thymic cancer, thymic hyperplasia or thymic cancer. And why that's really important is because if you remove the thymus, you get a marked improvement in 70% of patients if you remove the thymus. Okay, the best initial therapy for myasthenia gravis is anti-acetylcholinesterase drugs. Bump up the level of acetylcholine. Neostigmine, pyridostigmine, neostigmine, pyridostigmine, neostigmine, pyridostigmine. What's the most common adverse effect? Salivation, lacrimation, salivation, and diarrhea. Because acetylcholine is good for your neuromuscular junction, but acetylcholine can be bad for your saliva and your GI tract. Now, since this is just symptomatic therapy, people are gonna progress. And when they progress, if you've got a thymus problem, you should remove the thymus. And some people, even if you can't see anything on the thymus, if you remove the thymus, the problem gets a lot better. Now, what if you're 70 and 80 and too old to do thymectomy? For instance, the thymectomy as you age doesn't work because by the time you're 60, 70, your T cells are already programmed and it's too late to remove the thymus. If you're too old to remove the thymus, it doesn't work. We use prednisone because it's anti-inflammatory to try and calm the antibody production. But since prednisone is a steroid and causes all sorts of terrible side effects, skin thinning and stria and male pattern hair loss and elbow hairy hair, hairy lips, bald heads, acne, we want to get off of prednisone, so we use other immunosuppressive medications like, plasmapheresis and intravenous immunoglobulins are what we do for acute myasthenic crisis. But to get you off of prednisone, if you can't do the thymectomy, we use azathioprine and cyclosporin, get you off of prednisone. Azathioprine and cyclosporin and mycophenolate mofetil to get you off of prednisone. Azathioprine and cyclosporin and mycophenolate mofetil and tacrolimus, sirolimus, pimecrolimus. Tacrolimus, sirolimus, pimecrolimus to get you off of steroids. Thymectomy will work in a lot of people who are under the age of 60 and 70 to control the disease. Plasmapheresis and intravenous immunoglobulins are what you use in acute myasthenic crisis. Same patient gets Staph aureus, gets treated vancomycin and gentamicin, now in respiratory distress. How'd that happen? Did you know that gentamicin can inhibit the neuromuscular junction? Aminoglycosides can inhibit the neuromuscular junction. No way. Yes way. Did you know that you can have myasthenia-like condition from aminoglycosides? Yeah, you can. Proximal muscle fatigue improves with repetitive exercise. Aha! Proximal muscle weakness gets better with repetitive exercise. Aha! Who, Lambert? Eaton Lambert? Eaton Lambert or Lambert Eaton? It's actually LEMS. Lambert Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome is associated with lung cancer. If you remove the lung cancer, treat the lung cancer, the Lambert-Eaton myasthenic syndrome might get better. Ooh, the specific test. Ooh, there's a specific test. It's not electromyography. It's not electromyography. Also, electromyography is not one of the choices. Muscle biopsy and aldolase are for polymyositis. Anti-Joe antibodies tells you who you're going to have involvement of the lungs in polymyositis. So you're going to have a problem with Joe lungs. Acetylcholine receptor antibodies is for myasthenia, not for Lambert-Eaton myasthenic. By process of elimination, it's anti-voltage gated channels. Really? Really? Yeah. Write that down. Look it up later, man. Remember, there are certain of these things you're not going to know. It's a review course. A review course means you cannot review what you never knew. Myasthenia, as you need more medication to control the myasthenia, people started getting drooling and diarrhea. What do you do about it? Prednisone use all the time? Ooh, that's a lot of adverse effects. Cataracts and bone loss. Cataracts and bone loss and stria. Acne, male pattern hair loss, hirsutism in all the wrong places. Nah. And besides that, what's the steroids going to do for drooling and diarrhea? Nothing. Beta blockers don't control drooling and diarrhea. Cevimeline makes it worse. Cevimeline is what you give in Sjogren's syndrome to increase saliva production. This is increased acetylcholine just in the salivary glands. Cevimeline will make them drown in their drool. Cevimeline will drool drown because cevimeline increases acetylcholine in just your mouth. Pilocarpine increases acetylcholine and constricts your pupils. Edrophonium is not what's going to stop, because if you're on pyridostigmine, there's no point in using edrophonium. If you're on pyridostigmine, don't use edrophonium. If you're on pyridostigmine, adding edrophonium is like wearing two bras, one on the inside and the outside of your shirt. You don't need both and you look funny. Intravenous immunoglobulins won't help with drooling and pooling. The question here is, which of these is anticholinergic? And the answer is glycopyrrolate. Glycopyrrolate is a systemic anticholinergic, but why doesn't it make the myasthenia worse? How come if it's anticholinergic, how come it's not making the myasthenia worse if it's anticholinergic? Because glycopyrrolate is anticholinergic, but only at muscarinic receptors. So glycopyrrolate is for drooling and pooling and head and neck surgery, and glycopyrrolate is also for COPD. You use glycopyrrolate or glycopyrronium inhalers. Now for something completely different. Pseudohypertrophy of the calves. Pseudohypertrophy of the calves. Pseudohypertrophy of the calves is Becker's muscular dystrophy. Decreased hand grip. Decreased hand grip. Would that be in Becker, myotonic dystrophy, polymyositis, polymyalgia rheumatica, or small Asian women at a massage parlor? The answer is myotonic dystrophy, because that's the point. It's tonic. They can't release. They literally can't. They don't let go of the doorknob. Get off of my doorknob. Yeah. Oh man, look at that. I know about myotonic dystrophy. I know about voltage-gated, anti-voltage-gated antibodies in Lambert-Eaton myasthenic syndrome. I never heard about voltage-gated. I never heard about glycopyrronium for all those extra drooling. I'm so proud of myself.